Greetings. Let us talk about endoscopic evaluation of esophageal mucosa in a patient with gastroesophageal reflux disease. These are my acknowledgments. Please take time to read it. And when a patient comes in for endoscopy with complaints of heartburn, you need to keep in mind a few things that you want to evaluate. First, looking at the distal esophageal lining. If there is damage in the form of erosive esophagitis, or if there is a metaplastic change with the development of a precancerous lining, Barrett's esophagus, and as you go down the esophagus through the diaphragmatic hiatus, you assess the integrity of the diaphragmatic hiatus, checking the crural status for the presence or absence of hiatal hernia. And then once you go down into the stomach and retroflex the endoscope to check the lower esophageal sphincter and flap valve and grade the integrity by using the American Foregut Society grading. So now let us focus on the assessment of the squamous esophageal mucosa. So as you go down, you may see changes of metaplastic change. That is where the columnar lining of the stomach has migrated up into the esophagus, and biopsy shows intestinal metaplasia. And especially if the Barrett's esophagus is more than 3 centimeters, you know that this is a definite sign of acid reflux. So in this case, you don't need to do an esophageal pH study to confirm acid reflux. Just this finding is a definite sign of acid reflux. If you see a lot of damage, in this case, this is Los Angeles grading of erosive esophagitis, grade D. Again, this is a definite sign of acid reflux. So let us learn about Los Angeles grading of erosive esophagitis. Grade A is a longitudinal erosion less than 5 millimeters. B, more than 5 millimeters. C, then you start seeing circumferential involvement from one fold to the other fold, but it is less than 75% of the circumference involved with erosion. And if it is more than 75%, you call it grade D. So in this case, we have seen grade D erosive esophagitis. So if you go and see this one, this is Los Angeles grade C erosive esophagitis. Again, a definitive sign for acid reflux. When you see this, you don't need to do pH studies of the esophagus. This is a definite sign of acid reflux. For the sake of repetition, grade A, erosion less than 5 millimeters. Grade B, more than 5 millimeters when there is circumferential involvement, less than 75% of the circumference involved. Grade C, as you can see here. And grade D is more than 75% circumferential involvement. In contrast to grade D and C, where there is circumferential involvement across the folds with erosions, contiguous involvement, in grade B, you just see erosions, and again, a definitive sign of acid reflux. And these are definitive erosions. not minor erosions. These are certainly more than 5 millimeter multiple longitudinal erosions, but no circumferential or contiguous involvement across the top of the folds. So grade D, grade C, grade B all indicators of definite acid reflux. In contrast, when you see a small erosion like here, less than 5 millimeters, it is Los Angeles grade A erosoesophagitis. This can be seen in half of the normal population, so it is not considered a definite sign of acid reflux. And we're going to talk about it later. So let me repeat the grading. Grade A, less than 5 millimeter erosion, longitudinal. More than 5 millimeter, grade B. Grade C is circumferential involvement, less than 75%. Grade D, circumferential involvement, more than 75%. In a majority of the patients, when you do endoscopy for heartburn, you may see completely normal esophageal squamous lining. As we know, there is no sign of acid reflux like erosions. And when you see either normal EGD or LA grade A esophagitis, to document whether the patient has gastroesophageal reflux disease by checking the acid reflux or acid exposure time in the esophagus, we do what is called Bravo test. And in this, we measure the acid exposure to the esophagus with this monitor that is attached to the esophagus. And you also try to look at acid exposure symptom correlation to define whether the patient has gastroesophageal reflux disease. And we're going to talk about Bravo test later. So in summary, when you do endoscopy, you have more than 3 centimeter Barrett's esophagus, LA grade D, LA grade C, LA grade B, erosoesophagitis. These are signs of definite acid reflux. On the other hand, if you see LA grade A erosoesophagitis or normal esophageal mucosa without erosion, if you want to confirm the diagnosis of gastroesophageal reflux disease, you should plan and do the Bravo test. So when you decide to do endoscopy in patients with heartburn to document whether they have true acid reflux or not, what you should do is you should stop their PPIs for a couple of weeks, at least a week for sure, and perform endoscopy. If the endoscopy shows Barrett's esophagus or erosions, that's good. If it doesn't show, to confirm the diagnosis of gastroesophageal reflux disease, you should plan to do the Bravo test during that same setting if possible, especially if you have the facilities to do that. So it involves a lot of planning when you're taking care of patients with acid reflux or GERD, or presumed GERD, presenting with heartburn. I hope this is helpful. Thank you.